So I just want to thank you all for coming and welcome you here to this forum with two of the doctors who are leading Midi Health. And before we get started, I just want to send out a big thank you to Linda Grace, who has allowed us to conduct this happy home invasion. We're really, really grateful. And Linda is incredibly generous. She shares her home and opens up her home to causes and companies that she believes in. So we're super honored to be in that group. Thank you again. And I want to thank all of you for coming. And the purpose of this event is to introduce you to Mindy Goldman, who has joined us as our Chief Clinical Officer, and also to direct a lot of questions at Kathleen Jordan, who is our Chief Medical Officer. So I am going to speed read through some introductions here, because if I were to give all of your credentials and all of your incredible accolades, we would be here for a very long time. I will start with Mindy, who has been practicing as an OBGYN at UCSF for almost 3 decades, right? Am I right about that? And currently serves as the director of the UCSF Gynecology Center for Cancer Survivors and At-Risk Women. And her clinical expertise covers menopausal issues for women with cancer and at-risk women, side effects of hormonal therapies used to treat breast cancer and other cancers, and treatment-induced menopause, as well as vaginal dryness and sexual dysfunction. And then I also want to give the shout out to Dr. Kathleen Jordan, who is Midi's Chief Medical Officer. She has been such a champion of digital health companies for quite a while, going back to St. Francis, maybe? Yeah. So she built her own very successful practice here in the Bay Area, then became Chief Medical Officer at St. Francis Memorial Hospital, and was most recently a leader in women's healthcare startups, including TIA, which is both a brick and mortar and a virtual clinic for young women. And she's won tons of awards for her advocacy for the treatment of trans people, and pioneered a lot of diversity, equity, and inclusion initiatives in your fight to increase access for everyone. And then the last person I want to introduce, where is Dr. Heather Hirsch? Are you somewhere, Heather? There she is, raising her hand. So Heather is an incredible doctor and a member of our medical advisory board. She's the lead physician at the Menopause and Midlife Clinic at Brigham and Women's Hospital, which is the second largest teaching hospital at Harvard's medical school. She is also an avid educator, and she uses every social media channel known to man to get out there and bust the myths that are rampant around women's health in midlife, and particularly perimenopause and menopause. So she's a real champion and has been super helpful as we've been working together. So, all right, we're going to get started. I just want to start first, Mindy, with you, and ask a little bit, if you can tell us briefly, a little bit about your career path and how it led you to be involved with Midi.
All right. So I am from Maine and ended up in the Bay Area to come to UCSF for my training, and joined the faculty after my training. And education has sort of always been a big thing of mine, and I was probably on track to be our residency director when my life was completely upended when my closest friend got breast cancer at a young age, hadn't even had her first mammogram. And I ended up getting her into care at UCSF, really involved in her care. In the end, when things got really bad, she ended up dying after 18 months of her diagnosis. I actually went on leave of absence from my job and took care of her, and she died at home with her parents and her partner and me. And that experience was incredibly meaningful and just really, really intense. And it taught me a lot of things. One was, while she was going through her treatment, all of her treatment threw her into menopause, and she was looking for various sources to help alleviate symptoms. And she started finding, if she did Chinese herbs and integrative therapies, that had improved her quality of life. So one of the things I'm most proud of is her partner and I started a nonprofit and ran it for 20 years in her memory, providing funding for integrative therapies to improve quality of life. But it really opened my eyes to the benefits of those types of therapies and being more open-minded. And when I came back to work, I had this aha that I wanted to shift my career and focus more on women's health issues for breast cancer patients. And I ended up joining our breast care center. A lot of people here have talked to me about Laura Esserman. I joined with Laura, and I was really in charge of, I was going to do their follow-up program, sort of helping take care of people who'd had breast cancer and doing well. And what started happening is people would come up to me and say, hey, this person was thrown into menopause from chemo. How do I manage it? Or this person has sexual dysfunction, or they're having abnormal bleeding on tamoxifen, one of their drugs. What do I do? And I look in the literature and I'm like, oh my God, there is absolutely nothing out there. So fast forward 20 years now, I feel very lucky to have sort of developed a field, helped develop a field that bridges breast oncology and gynecology that's really focused specifically in women's health issues. And how do you manage all the survivorship issues? And I've been doing that for a long time now, and I love what I do, but one of the things that became very frustrating at UC was feeling like I wanted to have a bigger impact. And at UC, I see about 8 to 10 consults a week. And one of the reasons that I was so excited to join Midi is my hope is through a digital platform like ours that I can help influence the care of hundreds and thousands in a week and really make an impact in this field. So that's what brought me here.
That is an amazing story. Kathleen, how did we get so lucky to have you? What was your path to
Mindy was the draw. I get to work with the likes of Mindy and many of our advisors like Heather that know so much about women's health care and menopause in particular. But Midi really merges my passions, which is really about access. I'm a daughter of immigrants, and I certainly know many people that lack access. And then I was chief medical officer at a hospital in the Tenderloin where access is a major issue. I was going through menopause, and after getting some really not even guideline-driven advice from very excellent doctors.
Delicately put.
Yes. I kept getting, they're like, oh, if you want that, you have to go to this concierge doctor. And I kept saying, really? Like, that's the only place I can go? And then I've always loved telehealth for decades, even before the pandemic. I really think we can get a lot done. It actually solves some of the access issues that we see across the U.S. So Midi was like my dream. It was, access issues, right? Where I thought there was a huge need for women. And I get to interact with these great experts who actually solve my problems finally. Not that I have any.
Oh, we all have.
Yeah.
That is great. Thank you. So, Kathleen, one more for you. Can you just we get a lot of questions about how Midi interacts with your regular healthcare, works with the healthcare system. What does it replace? What does it do for you? Can you just kind of give everybody a rundown of how Midi works, just the nuts and bolts? I think everybody here knows that Midi is here to serve. It is a digital clinic that is serving women 40 plus and women who are thrown into early menopause. And so we specialize in the symptoms of perimenopause and menopause, but also sort of all the wider challenges that come up in midlife. But can you run us through sort of how it works, the nuts and bolts of it?
First and foremost, we're an access point to healthcare. I've been seeing patients at Midi, and women are coming in for a variety of reasons. Some of them have seen 10 doctors, and they haven't liked what they've heard, or they've heard conflicting things, and they want you to help digest the information. Or I have a patient, she has her naturopath, and she has her OB-GYN, and she has her internist, and then she comes and helps sort out the science between the three. Then we have other women who just don't have the time to go to the doctor. They're taking care of their parents, they're at the peak of their career, they have teenagers, they're flying around for work. Many of them with the pandemic haven't seen a physician for a couple years. So how we work it at Midi is we want to help all these women. That's you, right? You know who you are. We want to help all these women. So to responsibly sort of address hormone needs in particular, we really need to be on top of your breast health, your cardiovascular health, and your bone health, because they're all intertwined. So we need to have tests done, right? We need to know what your mammogram is. Want to know it's up to date. So if you have a healthcare home that you love, you stay in that healthcare home, and we work with them as a consultant. If you are behind in your mammogram, or you're behind and you haven't had your cholesterol checked in a while, we order labs through LabCorp or whatever neighborhood lab places near you. We will order your mammograms. We found about at least, I think it's 40% of the women that have come to see us thus far haven't had a mammogram done, so we do order those because they need it and they're behind. So we sort of help with the primary care. We don't do acute care. Like we're not where you go to for your cough, your sinusitis. But a lot of the chronic issues that come up in midlife, we do help with. So osteoporosis, sleep, mood issues, bone health, vaginal health, pain with hot flashes for sure.
Let's see, skin and hair, weight and body changes, mood changes, anxiety.
Yes. The many things that are affected by the hormone depletion we're seeing. And we're not a hormone replacement company. So we're not a one-trick wonder where estrogen is the magic for it all. We do appreciate that the changes in estrogen affect so many parts of us. So for instance, you may not be eligible for hormone replacement therapy due to having certain cancers, or you may not want hormone replacement therapy. There's other treatments we have for hot flashes. There's other pharmaceuticals that are non-hormonal. There's also naturopath remedies. So we commit, our clinicians have a team behind them that create protocols, and they're educated in all those solutions. So we seek to understand your issues, and they're informed sort of by your midlife experience, and then we match you with solutions that will help you feel better.
So you just talked about protocols, and I know Mindy has been working with us as our medical advisor for many months. So we've been working her really hard before welcoming her as our Chief Clinical Officer. You've been working on these protocols for months now. Can you tell us a little bit about what goes into those protocols? Those protocols are the thing that guide all of our care, but what goes into the protocols themselves?
Yeah, so I am incredibly proud of sort of what we're doing with the care that we are providing. So to give you an example of what our hot flash protocol is like, and I'll tell you both what goes into it and what's so unique and special about it. So what goes into it is we will look at the literature, and based on, I wrote many of the protocols, Kathleen wrote many of the protocols. We also we have a naturopath working with us who helped write some of the protocols. We go to various sources to make sure that everything is all evidence-based in what we're providing. And then we have expert advisors, people like Heather Hirsch, people who are experts in different areas of medicine. And for those advisors, we may ask them. We have a advisor who is an expert in brain fog, who's one of the prior presidents of the North American Menopause Society, and we'll say, can you give us feedback on our brain fog protocol? So we're getting expert advice after we've already developed these. What I am really proud of, if you look at something like the hot flash protocol, nowhere that I know of could someone go and get one sort of guideline or reference manual that talks about hormones to treat menopausal symptoms that are all evidence-based and consistent with North American Menopause Society, sort of the leading guiding organization. Alternatives to hormones. I have been lucky to work with the National Comprehensive Cancer Network, and we've provided guidelines on alternatives to hormones. We took all that information and put it into our protocols. And then on top of that, a lot of women are interested in natural therapies, and we have naturopaths that are helping us with evidence for natural treatments where they exist. So these protocols encompass all these many different things. So if you are coming to us and you're complaining of hot flashes disrupting your sleep, and you're interested in knowing, are you a good candidate? What are the risks? What if I don't want to use hormones? What if I want natural approaches? We have all of that in one guideline that helps our nurse practitioners who are giving the frontline care be able to treat you with the most up-to-date information.
Yeah, and we've gotten feedback from our clinicians that they have not found any resource like this. There's no place where it is all brought together for them. So it's taken, I mean, each of these protocols, give me a back of the envelope, how many hours, how many goes
Probably
into
around
these?
30
Yeah.
or so hours to develop a protocol.
Which doesn't really count getting subject experts in to,
Yeah, just kind
Yeah.
of the background and being able to work together, writing them, going to various sources of literature and guiding organizations to make sure that everything we are writing and going to be guiding patients is all evidence-based and up to date with the most up-to-date literature.
and they're going to constantly
And they're going
evolve,
to constantly
yeah?
evolve as more information comes out. We're going to continually need to update things so that we are constantly providing people with what's up to date.
So you are our survivorship expert. You are the person anyone would go to create this protocol. So thank heavens we have you. Although I know you're bringing in other people, talk a little bit about the survivorship protocol and what it is, in general, this sort of subspecialty in survivorship. What does that mean? Who are we helping, and what are we doing for them?
What I know the most is about breast cancer survivorship, and that is certainly the most common. There's 4 million women who living in the U.S. who've previously had breast cancer, 250,000 new cases of invasive breast cancer each year, and it's most common in breast cancer survivors that they're coming in to say, how do I treat my menopause symptoms? Everyone says I can't take hormones. And for most breast cancer survivors, they probably shouldn't take hormones. Turns out there are certain subtypes. If someone had hormone receptor negative disease and they've been free of disease for a long time, that there is no data that says the use of hormones increases the risk of recurrence. So many of what we are developing in our survivorship protocols is not just for breast cancer, but protocols that help anyone who's previously had cancers know what are treatment options for me for managing hot flashes. A lot of cancer patients get chemotherapy and get thrown into menopause. For breast cancer patients on certain...
And sorry, just to clarify on that, I remember you telling me that when your menopause is triggered by cancer treatment, it's generally worse than what natural menopause serves up, which is also no picnic. So
yeah, so there's a number of reasons why it tends to be worse. One is for people who were taking hormones and then they're diagnosed with breast cancer, they tend to cold turkey stop their hormones, even though there's no data that says they really have to do that, but they tend to do it. For premenopausal women who get diagnosed, if they get chemotherapy, it stops their ovaries from functioning and they get thrown into menopause. It may or may not be permanent depending on how much chemo and the age of the person. For many patients, they get put on drugs like tamoxifen or aromatase inhibitors, and those drugs can cause hot flashes. And then for some people, if they have normal ovarian function, their ovaries may be removed as part of their breast cancer treatment, and that throws them into surgical menopause. So in all those scenarios, sometimes the symptoms are more severe. So that's just one example of what we're developing. People like that are coming to us to say, what's safe? What can I use? Do I have to suffer? Sometimes docs are saying, just live with it, suck it up. They develop not just hot flashes, but vaginal dryness, sexual dysfunction, sleep dysfunction, mood issues. So our protocols, we have sort of guidelines for treating all those issues, and then ones that are specifically devoted to people who've had cancer, as well as some people who haven't had cancer, but they may have a family history of cancer. And they're worried about, can I take hormones? If I don't want to take hormones, what are options for me? So those are the sorts of things we're developing.
Yeah. 3 words you will never hear coming from a Midi clinician are, suck it up. That's not going to happen. Okay, thank you. I think that, we'll get into more questions from people who are here, but I think that really gives us a good overview. Okay, so question for Kathleen. For women who are eligible for HRT, what do we know HRT can help with? What is the sort of party line on what it can help with? And what do we think it might be able to help with?
Keep me honest here. So I think incontrovertible is it helps hot flashes. And
Louder.
it helps hot flashes, right? It helps them go away. I think women underplay how much those can affect you. They're not painful, but they actually affect your sleep more than I think women think, and sleep affects so much of our health. It also affects their mood and affects depressive symptoms. So I think there's a wraparound to that, but it definitely just purely helps with hot flashes and night sweats. And it helps with your bone health. And then we'll say, I have not had a patient come to Midi yet saying, I really am coming here for bone health. But fast forward 10 years, bone health is going to become a bigger thing for us. It's really in the next decade of life where we start to get compression fractures and as well as traumatic fractures. So bone health is super important in a preventative way to keep us healthy for longer. Hormone replacement therapy decreases our bone loss. Is that a double negative?
No, it works. I get it.
Does it work? And helps us maintain good bone health. We know those to be true, right? We also know more than that, but it gets a little more nuanced because it's in certain categories, right? So we know it helps sleep in patients who have hot flashes and night sweats. There is also some evidence that it helps sleep in women who don't have hot flashes and night sweats. There's definitely evidence on vaginal health. And what percentage of women do you think have vaginal issues with dryness or pain with sex?
90.
It is the majority. It is over half, right? And women are continually surprised that there's solutions for this. There's systemic estrogen therapy, but there's also topical therapy, and we have an expert in the audience who can go into more later. So in midlife, we know as estrogen decreases, our actual average blood sugar goes up, and actually our lipid panel actually worsens. So our LDL goes up, and our HDL worsens. So we do know that it affects our metabolism there. We also know that it affects our skin. So estrogen helps us keep our skin moist. It also helps with collagen deposition, skin thickness, as well as wrinkling. These are all the issues that come up and more.
Anything else you want to add to that?
I'm just
Mindy?
going to add the number one cause of death is heart disease, and we know that the estrogen that the ovaries produces protects against heart disease. And there have been controversies over whether hormones impact heart disease positively or negatively, and we know that there's a difference in the risks and benefits of hormones depending on the age of a woman when she starts. But for women who start hormones within 10 years of menopause or under age 60, hormones are actually preventative for heart disease. And so there's a lot of people right now, the guidelines are just to use hormone therapy for treating symptoms. But, oh, by the way, if you're under 60, you'll also get cardiovascular prevention. There's been some question whether the U.S. Preventive Service Task Force was going to change the guidelines to say women should take hormones for prevention of disease, but right now it's just for treating symptoms.
All right, so this is a question for both of you. Either of you can take it first. But what I feel like I've gotten from you that's been most surprising and exciting is that in the process of developing these protocols and training the clinicians on them, you yourselves have learned things you didn't know and discovered things and are exploring areas that are really novel. And so can you share a little bit about some of the things that you're fascinated by, that are coming up, that feel new?
Well, one of the things I feel so lucky to be part of this, and my learning curve has been like this, and I get to learn from people like Kathleen and everyone. I'm learning a lot about the whole practice of medicine in this kind of digital health format. But I'm also learning medicine. So I didn't know that ferritin levels actually affect sleep.
Ferritin levels are?
Ferritin levels are a function of our iron
Is that your
stores.
iron? Okay.
And if your levels are low, that can be one of the reasons you may not be sleeping well. Never in all my years of practice did I know to check a ferritin on someone if they're coming in for sleep dysfunction. So that's just like one of 1,000 examples that I find I'm learning every day of little tidbits from the experts that we have that are involved in developing and helping us vet these protocols.
Yeah.
What about you, Kathleen?
I think the effect of estrogen on our metabolism is super interesting, and I think there's a lot of evolving science around it. we know from the Women's Health Initiative study from, it was in the 1990s. We've known for a long time, even in that study, the women on hormone replacement therapy had a 30% less incidence of developing diabetes, which is amazing. It's not really talked about, so it definitely affects even glucose metabolism. And I think that's very interesting. The effect it has on our cholesterol and lipid is super interesting. And then the tie-in with women, and is cholesterol really linked to the risk of stroke? Because many of the studies were done in men. So I think there's a lot of evolving research on this that I think is super fascinating and I think super applicable given that it is the #1 killer of women. So the commitment at Midi is we stay on top of this. I can counsel you on what current thought is on that. But I think that's really fascinating.
Can I add one thing?
Of course.
The other thing that's kind of, I think, is really interesting about this kind of format for providing care, as Kathleen said, we're getting labs on a lot of people, and it allows us to study things. So we're getting labs as part of people's general health. But for example, one of the tests we're doing is a test called anti-Mullerian hormone. And there's some studies that suggest that may be predictive for time to menopause. And it's still controversial about whether it is. But if you have a platform like this where you have data on lots and lots of people, it allows you to have a better understanding of, it allows you to do research and really understand potentially how things are, understand certain diseases and how it manifests and things like that. So,
Yeah.
yeah.
Let's go to questions.
Yeah.
Yes. So, the question is, why is hot flash duration so different in different women? Why do some people have them for just a few years and others it goes on and on?
25% don't have them.
Yeah. So
That's even more fascinating.
I think what's fascinating is take the question back of, why is it that some people breeze through menopause and have almost no symptoms and other people are completely disabled? And I would say we don't have a good handle on that at all. One of the other things, we're hoping to look at lots of different things, like there's some research saying the gut microbiome may play into how menopause manifests. So that's an area we're hoping to be able to look at and develop protocols related to people's digestive health. My understanding of the data is that about 85% of people will have symptoms in the first 1 to 3 years, and then they tend to be pretty mild after that, where they may have a hot flash now and then, but not really bothered. But there's about 15% of people that persist in having them. We don't understand what is it about those 15%, but for those people it tends to be a problem for the rest of their life. May not be as severe as it was early on, but oftentimes they're the people that seek out treatment.
Definitely.
Yeah, so the question is, given the fact that some women have symptoms that go on for such a long time, when does a woman have to, or does she have to come off of HRT? There are new North American Menopause Society guidelines out. Are those shifting a little bit?
Actually, the guidelines don't say you have to come off. What they say is actually that you may think twice or look for alternatives to start them late. So the women who have not had the risk-benefit ratio that favors starting are women that start late. Is that fair to say?
Yeah.
Yeah. But
Okay,
women that
so
have been on it since the time of menopause, there is no hard and fast time that they have to come off.
So if you start late, you may have to have a shorter duration, but if you start early at sort of what the appropriate time that Midi would start you on them, then you can have a longer runway.
Yeah. I'm actually, let me just take it back. I think, a lot of how we counsel women was based on this very large study called the Women's Health Initiative, which was sponsored by the NIH and one of the, sort of the gold standard of studies that looked at whether the use of hormones was associated with a higher risk of certain disease or beneficial for certain diseases. And that was done 20 years ago, but has still affected how we think about hormones. And some of the concerns when it comes to, and without going into sort of all the details, because I have like hour talks on the WHI, it turns out that the risks and benefits of hormones differ depending on the age of the patient and years since menopause. So if women start hormones within 10 years of menopause, the benefits tend to outweigh the risks. But if women wait till they've been menopausal for 10 years and then start hormones, the risks tend to outweigh the benefits, and specifically with higher cardiovascular and stroke risks. So depending on what specialty in medicine you are, if we know the average age of menopause is 51. So a lot of internists or primary cares will say, oh, as soon as you hit 60, you should stop your hormones because the risks outweigh the benefits. But we now know, and this is reinforced by the new guidelines from our leading guiding organization, NAMS, the North American Menopause Society, that if you had someone who started early and is doing well on their hormones, just because they turned 60 or older, they don't need to stop their hormones. You need to talk to people about risks and make sure that they don't have risks specifically for heart disease and strokes, like uncontrolled hypertension. But if they're doing well, don't stop them just based on age alone. So I see a lot of people, and if someone is, the big thing is if you're 65 or 70 and you're coming in and you haven't been on hormones for 10 years, then the risks slightly outweigh the benefits. Doesn't mean that you absolutely can't do it. You shouldn't take it. But I think that's one of those situations that our role as providers are to talk to you about the risks and benefits, look at your own personal health history, and help you make an educated decision whether it's right for you.
And does monitoring play a role in this too? Like sort of, you know, if a woman is staying on hormone replacement therapy, there's a certain amount of monitoring you do to make sure that she's staying okay? Is that right to say?
The monitoring is checking on symptoms, mitigating cardiovascular risks, making sure they're up to date on their breast health. So
Yeah.
it's really kind of all that.
Okay.
The one thing I want to also emphasize, though, is there are studies that show women self-reported quality of life is better on hormone replacement therapy. So when women have been on it for 10 years and turn 60, they do not want to come off. And there isn't actually evidence that says that they should. Again, this is evolving science. We're now tracking people. The problem with the Women's Health Initiative study is that many women stopped. So we don't have the long-term data from that, but there are other studies. There's a lot of studies in Europe, right, where we have national databases from National Health Services, and they actually show women do well with long-term therapy.
Awesome, interesting.
Can I make one comment that I do, because a lot of people will ask about this? Those women that were in the Women's Health Initiative have been followed now for 20 years plus, and they have looked at health outcomes, and my big focus is breast cancer. This was published, most people don't have a handle on this, but this was published only a year and a half ago, 20-year follow-up. When people took their hormones in the Women's Health Initiative, if they have a uterus, they take estrogen with some form of progesterone to protect the uterus from uterine cancer. If no uterus, they take estrogen alone. The women who got estrogen alone versus a placebo actually had a lower risk of getting breast cancer, statistically lower risk of getting breast cancer, and lower risk of dying of breast cancer. So it really throws, like we've all been taught, oh, hormones cause breast cancer. It really is much more nuanced than that, and estrogen alone, we now know it's the progestin component, and the types of progestins that we now use are different than what they prescribed 20 years ago and may not have the same risks that were associated with those types of progestins.
Interesting.
Consider hormones.
Okay, so let me see if I'm rephrasing this correctly. No, it's a great question. So when, if you are a few years out from menopause, I think what you're asking is, how far out can you go? No?
No. I know the answer to that.
Okay.
Miss the window? Do you
No,
miss the window?
I know the answer is 10 years. If you're within the 10 years and doing okay, right? No.
I see.
Why would you,
Yeah, sure.
why,
So-
would- why would you
But,
start?
Okay.
but what has changed is the data has changed
Right.
from when you went through menopause. So when in those situations would you say, you know, it's not too late. I might have done something different 7 years ago. What do I do with you? You know, what's the thinking now?
How preventive?
Yeah, so
Is
I'm happy to
HRT the
answer that.
option?
So, you know, that we do know that the risks and benefits differ, and that there are preventative benefits in terms of cardiovascular and bone health, but none of the national guidelines currently say that you should be putting someone on hormones solely for prevention of disease. That's what I was mentioning. They were questioning whether they were going to change that, but the current national guidelines are you should use hormones for treating symptoms. And oh yeah, by the way, if you are within 10 years of menopause, you will get cardiovascular protection. And if you're more than 10 years, the risks outweigh the benefits. So most people would probably say, I probably wouldn't put you on hormones. But if you have some symptoms like sleep dysfunction, I think one of the interesting things, there's a lot of symptoms that people don't realize hormones may be beneficial. Maybe you don't have the classic hot flashes or night sweats, but maybe you're having sleep dysfunction. And maybe you're having palpitations. That can be a sign of menopause. And it's possible that hormones could alleviate some of these other things. So one of the things that I think is really important is to look at someone's, total symptoms and not just assume that something like palpitations is due to a heart problem, or, that they're sleep issues, they're waking up early and it's due to a mood disorder. So
Okay, so the question is, if there are benefits to HRT and you go on them and they help to prevent bone loss, but then you go off, do you wind up back in the same position with a lot of bone loss as soon as you go off of it?
No, there's not a double cliff. But really, so your bone's constantly going through turnover, so you're making new bone and you're destroying old bone constantly. And what happens when your estrogen depletes is you get the balance off and you lose like 2 to 3% of your bone density per year. And then it slows, the first few years of menopause, it's a couple of percent. After that, it slows down the loss, but you still have a loss. If you take estrogen, you'll actually get a little bump. You may not go all the way back up here, but you'll get a little bump. But you're stopping the loss, if that makes sense. So you're basically holding it at bay. Then you will just get the continued 1% bone loss after that, if you came off.
the amazing thing is you actually reach peak bone density at 30 to 35.
So
everyone has a decline after that.
Right, so estrogen is a treatment to prevent bone loss. It's a preventative treatment. It's also sort of a second-line treatment for osteoporosis, and it augments first-line treatments for osteoporosis as well. So,
the question was, I think I got this right, can you talk a little bit about brain fog and cognitive issues as a symptom of menopause, and also about migraines, the potential relationship there?
So there's a lot of people that have menstrual migraines, migraines that are a part of PMS symptoms, premenstrual syndrome. And for some people, their migraines worsen around the time of perimenopause. For some people, they get better. But we know that there can be headaches, may be a manifestation for some people of menopause. And that's what I was talking about. It is important to kind of look at the total picture. And so would I recommend hormone therapy solely for those? Not necessarily, but kind of looking at the total picture. It depends. And if someone didn't have risks and they told me that their headaches were better when they were cycling and they got worse at the onset of menopause, I might be willing to say, if there's, let's consider trying. Brain fog, I think, is a really complex issue. A lot of people worry, I've got brain fog and I'm getting dementia, right? Well, there's a lot of issues, though, during menopause. A lot of people don't sleep as well. Some of it may be temperature dysregulation, right? That you get hot flushes that wake you up. But there's been interesting studies that actually showed that it's not just all the temperature dysregulation, that menopausal women actually, even if they were having kind of mild hot flashes, if they were able to get into a deep REM sleep, that it didn't bother them. So there are some people that just don't get into that deep REM sleep, and there's parts of sort of the sleep issues that we don't understand. It's important for us to make sure there aren't other things like restless leg syndrome or sleep apnea going on. So one of the biggest things that I think when people present with brain fog is we really try to look at lifestyle, and we look at, what are they doing? We look at their sleep. I find that's one of the biggest thing. You can talk about
Are you guys coordinating with Aura or other,
I'm just curious, as a platform, if you'll coordinate with data on other, like, sleep issues.
We're certainly talking about it.
we are, and I've been trying all of them to. So they are interesting. We actually recommend them because I think they're very motivating for patients, right? So I have a patient who isn't sleeping well. She stops caffeine. She stops reduces alcohol. She sees the number change that sleeps well, and then that reinforces the habit. So I think they're very motivational.
Yeah.
So we do look at the data and sort of help use it in that way.
We're also trying to get some of the sleep experts, like some of the Stanford sleep people, to help us in looking at our protocols to make sure that we are thinking very broadly in everything that we are thinking about. But again, I do think that brain fog is one of the areas that we also will sometimes say, hey, let's try hormones and see if it does improve your cognition, your sort of like, I think brain fog sort of, people think of it in different ways. Some people like, I can't get the right word, I'm losing my mind, I'm getting demented, so we look at like all the specific complaints and then think, okay, what are all the different lifestyle things we can do? Maybe try hormones.
Well, I think a lot of women want to hear that it's normal. I mean, there's studies that show your memory does get worse in midlife.
But is there
you're
a
still
rebound? Do we get our brains back at some point? Is there a point? Does it sort of peak, that sense of mental fog, and then clear a little bit later on?
I've never seen it quantified.
I think there is. There's a neuropsychiatrist at UCSF, Luann Brizendine, who actually just wrote a book about this. And my understanding is that the brain fog is worse during these hormonal fluctuations. So worse at the time of perimenopause and soon after menopause. But after women have been years without hormones and it's more of a steady state, that for many people they do get some of their so-called brain functioning back. So
That has been the case with me. So there you go. All right. Yes. So is the question, that the symptoms, there are initial symptoms, and then there are new and ongoing symptoms, and so further out from menopause, what can we do for symptoms
Well, again,
that are
the
ongoing?
answer for everyone is not hormone replacement therapy, right? So the risk-benefit ratio may change when you're post 10 years, and you may not go on hormone replacement therapy. But it's also nice that you're seeing an expert that knows that your incidence of sleep apnea goes up and you might need a sleep apnea test, right? You can do a home test, you can go to a sleep lab. There's also other medications you can take.
It's not sleep apnea.
Well, no, but there's a whole host. Restless leg syndrome doubles. There's a lot of other things around sleep. There's sleep hygiene. There's always the question, does blue light affect my sleep? Should I take melatonin? There's a lot of people taking magnesium supplements. So we kind of walk you through all these things. So walk you through sleep hygiene. We do tell you to exercise though. So exercise is the magic bullet for so many things. It affects your metabolism. It's not just about weight and looking good. It actually affects a lot of things. It affects your mood, it affects your sleep.
they decrease your risk of breast cancer.
Yeah, I mean, exercise is wonderful, so we will also tell you to exercise. But
Awesome. All right, now I'm going to throw a question out here. I feel like I hear everywhere I go that women in midlife are not having sex, or they are not enjoying sex. Sex is no fun anymore, or they just don't want to have it. It hurts, whatever. Tell us what is going on. What are the issues that are coming together here?
So I'm happy to take that one. So, as a gynecologist,
we all looked at you.
We see this a lot. So it's important to realize that more than 50% of women will come in with complaints of vaginal dryness, but people don't talk about it, right? So one of the big issues with not having sex is it hurts. If it hurts to be touched or have penetration, it typically sets something up of who wants to do something that's painful. So as a self-protective mechanism, people aren't having sex. So the first thing is we need to address, do you have dryness? Does it hurt to be touched? We know that estrogen affects the vagina, the outside vulva, the bladder. People can get urgency, frequency, irritation on the outside, dryness on the inside. So that's one of the things that we can treat. There's over-the-counter things that, if they're used regularly enough, can make people feel better. Vaginal estrogen actually changes the tissue. It improves blood flow, which can improve the tone, which makes the tissue so it's less uncomfortable. Once you treat dryness, then we want to know, for some people that's the main issue. For other people, they may have low desire. And there's actually now, this has become a whole field within female medicine looking at female sexual functioning. And there's actually FDA-approved drugs for treating low desire. Now, unfortunately, the drugs that are out there are FDA-approved in premenopausal women, but they can be used off-label in postmenopausal women. There's also off-label use of the male hormone testosterone. That the good data looking at that is improving sexual functioning in postmenopausal women. So there are a lot of things that can be done to. A lot of people aren't having sex for maybe many reasons, and I think it's our role to sort of unpack that, separate out the dryness, treat the dryness, look at relationship issues, look at desire. But the biggest take home is that, like, there's no reason that you can't be having sex.
Okay,
Is that a
good.
good way to end things?
Yes, that is a good way to end things. So our doctors can be mingling around. You can ask them questions one-on-one. We have a few more minutes for that. But thank you, everyone, for joining us. This has been really, really interesting. And thank you mostly to our doctors.
Thank you.
Great.